Good morning, everyone, and welcome to today's webinar. Again, it's on KHCF CMS mandatory testing. Before we get started, just a few things regarding today's webinar. If you look to the right side of your screen, you'll see like an orange arrow. You can click on it to close it, and then you can also click on it to open. Again, make sure you're aware of that particular dashboard. It's your like little small computer desktop. And in that feature, there's a question feature and also a feature for chat. So again, we want you to make sure you find that so that during today's session, you can type in your questions so that we can answer those at the end of today's session for you. And again, I know many of you have called in too. So again, just if you have questions and want to let us know those, you can certainly email your questions to us after today's session. And before we get started, also I want to recognize we have our pledge partners, which that'll be featured in today's webinar, that are part of our platinum membership that have supported us again throughout 2020. And you'll see with this we have 19 different platinum members that are supporting our association with our educational offerings. And with us today we have Ashley Christensen and Wayne Johnson. Again, Ashley is our Director of Regulatory Affairs. Many of you all probably called, text, or visited with her, but if you haven't, this is your chance to meet her. She, again, is in charge of our regulatory and survey and has been on the front line regarding COVID and what has been going on since basically March with that. And then we have Wayne Johnson, our Vice President of Finance and Chief Financial Officer. And again, Wayne is with us today to answer questions. Again, I know many of you may have regarding reimbursement with the COVID-19 testing. So again, I want to turn it over to Ashley to start our presentation.
Thanks so much for joining us, you all. All right, we're just going to jump right in because we have a lot to cover, and I'm sure folks have a lot of questions. So we're going to get to questions at the end. But if you do have questions or comments as we go along, feel free to type them in kind of as we go. And if we have a chance, we'll kind of address them as we go. So the guidance, if you haven't seen the guidance yet, please take a look. On August 25th, they issued, CMS being they, issued a memo outlining the mandatory testing of staff and residents when triggered. This guidance went into effect on September 2nd. So who is staff? Staff is defined as employees, regardless of who, what their title is, so all different levels, contractors who come into your building, consultants, students, and volunteers. So uncannily, this rule does not require testing of surveyors and ombudsmen, but here in Kentucky, I will note that surveyors, you know, we've asked this question repeatedly. The cabinet cannot mandate surveyors to be tested. They've asked that question. It is something that they've been kind of working on, but testing is available to them on a weekly basis. And when they come to your building, please make sure that they are screened at the door regularly, just as any other visitor would be screened. And they all should have their own PPE to enter your building. They've had CARES Act funding provided to them, and they should all have their own PPE. All right, so triggers for testing. There are 3 different triggers for testing. There's your routine staff testing based upon their positivity rate in your community, which is defined as your county. There's symptomatic testing, and then there's outbreak testing. And we're going to go through all 3 different categories. So routine testing of staff and your contractors. The frequency depends on the prevalence in your community or your county. Low is less than 5%. If your county is less than 5%, that's once a month. If your county is medium, which is 5 to 10%, you'll test once a week. And if your county ranks high, some people are calling this a red zone, is more than 10%, you'll be testing twice a week. Now, this presumes availability of point of care testing on site. This is that machine, this device coming from Medicaid, CMS, or off-site testing with a turnaround time of less than 48 hours, such as the state surveillance testing program, which we'll talk about a little bit later. Most of you are familiar with that. If testing is not available, you all must call the state or local health department and document your efforts to obtain testing. So routine testing, we're talking about this again. Routine testing of asymptomatic residents is not recommended or required. Individuals who tested positive don't need repeat testing for 90 days. Staff can be tested elsewhere if it's completed in the same time frame, and make sure those results are documented. I think if I were running a facility, that would be really confusing to keep track of all of that. So I think I'd probably not recommend that. So additional testing triggers, staff and resident. So if you have symptomatic, so anybody who have signs or symptoms of COVID-19, you will test anyone who has signs or symptoms. That's your symptomatic testing. Then if you have outbreak testing, test all staff and residents when an outbreak occurs. This is defined as any single new infection in staff or resident who tests positive after admission. Continue to test all staff and residents who tested negative, and then every 3 to 7 days until no new cases for at least 14 days since your most recent positive result. And I know this can get kind of hairy, so I know some folks have a lot of questions about this. We can talk about this more. Okay, so folks I know this kind of got confusing at the beginning because I think the state sent out a source for finding your community rate. And if you look at the state data, when the governor is giving community rates, you have to be really careful because the state's data is a little bit different than what CMS puts out. I would strongly recommend that you go by this link that was in the guidance. So CMS publishes county level positivity rates at this link. So I would strongly recommend that you follow this link. Facilities should monitor and adjust testing frequency based on the changing positivity rates. They recommend that you check those rates on the first and the third Mondays of each month. If the rate decreases, they recommend, actually they mandate that you continue testing the staff at a higher frequency. If you're in that red zone at the 2 times a week, until you're down to the lower rate for at least 2 weeks. If the rate increases, then you'll immediately adjust your testing frequency. I hope that makes sense. Documentation requirements. So you must document in your medical or employee record. You'll keep a separate file for contractors and volunteers. Documentation does vary for testing reasons. So if somebody is symptomatic, you'll note the date and time of identification of their signs and symptoms. You'll note the date and time, date of the test and date of the results obtained and the results and actions taken. If it's an outbreak, you'll note that the date of the first case that was identified, and you'll note the dates and results of the initial testing and retesting for all of your residents and staff. Now, if it's just routine staff testing, you'll want to keep a log, probably is the best way to do this, of your county positivity rate and testing frequency that was required, and the date the positivity rate was checked on the CMS website, and also the dates and results of all of your tests that were done with your staff members. So if you have somebody on your staff that refuses to take a test, and this probably will come up for some of you, you must have a policy and procedures for folks, either staff or residents who refuse. So make sure that you go ahead and develop those now if you don't have those already. And then you'll want to document procedures if somebody does go ahead and refuse. So for a staff refusal, for an outbreak situation, you'll want to restrict a staff member from the building until the procedures for outbreak testing are complete. For routine testing, you'll want to follow the occupational health and local jurisdiction policies. So for routine testing, I would say I've looked into this. I don't know of any occupational health and local jurisdiction policies, and I've been asked about this many times. If anybody on this call knows of any policies that we should follow, please let me know. I've done some digging into this, but if a staff member does refuse, to my knowledge, the best that I know of at this point is that you can still allow them to work. So if somebody knows of a different answer, please let me know, because to the best of my knowledge, I don't know of any other guidance at this point. If a resident does refuse, residents with signs or symptoms of COVID-19 who refuse testing are placed on, of course, transmission-based precautions until criteria for discontinuation are met. Let's see, hang on one second. Okay, let's see, other requirements. So all of this testing is going to require physician order for both residents and staff. Standing orders are allowed. So you'll want to get your medical professional to go ahead and make that standing order. You must also follow CDC guidelines on testing and specimen collection. If you're using the point of care testing, which is that device that comes from CMS, you should have your CLIA certificate for point of care testing, and then you must report negative and positive test results to the public health agencies. And we'll talk about that more in just a second when we talk about point of care testing. So the two different types of testing that are permissible under this guidance are either PCR or antigen tests. Please note that antibody tests don't meet the requirements under this guidance. So I know there are so many different types of testing and testing devices and different there's so many different words and phrases and floating around, but just remember a PCR, antigen are permissible, antibody, no. So antibody, remember, is down, it shows after you've already had the virus, it shows those antibodies in your system. That's not permissible under this guidance. In Kentucky, you can choose to use either the state surveillance program or the CMS point of care device that you receive, or down the road you receive it from CMS. But keep in mind there are different considerations to come, that'll come to mind for each of these programs. So first, let's consider the CMS point of care test devices. So these are antigen test devices. These are not PCR tests. Nursing facilities will receive one of two different test devices. This is the CADEL, I think is how it said, Sophia 2 SARS antigen FIA, or the BD, or the BD Veritor system for rapid detection of SARS-CoV-2. Okay, so some states, I don't know if you have multi-state facilities, you'll know that some states are not allowing point of care testing. Here in Kentucky, yes, our state does allow these point of care testing devices, but per the OIG and the Department for Public Health, the state surveillance testing is preferred. But those point of care devices are allowable. Per the Department for Public Health and the OIG, the state surveillance testing, and when I say that, I mean like when you send those, swab and you send it off to a lab, those PCR tests are just more accurate and reliable. So that's one of the main reasons that they prefer the state surveillance test. The second step, if you're going to be using this point of care test device that you receive from CMS, you'll want to review the CDC interim guidance for rapid antigen testing to understand the limitations and the caution of these devices. And I've included a link here. And then AHCA has also provided a summary of the guidance. Keep in mind that if you use this point of care test device, you're under this guidance considered to be a lab because you're conducting these tests. So you're required to report all of these test results, both positive and negative, to the state and local health departments. And one of the curious things is some other states have developed a really nice system for doing this. I think Kentucky is working on this, but so far, no dice. So you'll be responsible for coming up with a mechanism for doing this every single day if you use this point of care test device, whether that be through an email or a log. I'm not exactly sure how, how it would best work for your facility, but you'll have to work that out for your facility and your local and state health department. And keep in mind that failure to report timely and accurately can result in CMPs. And you'll notice as we go through these considerations, there is a weight placed on one over another. Okay, so step 4, if you're wanting to use the point of care test devices, you'll have to complete the training to make sure that you're using the device properly. So I've included links to the 2 different devices so that you have the website so that you can do the training. And then you'll have to make sure that you process to record all test results and notify the individual person of their test results. And then, it said you may need to purchase a printer for your device to print the results of each test performed. And then you'll also, of course, have to incorporate the use of these testing devices into your facility infection prevention and control program and facility assessment. So you'll make sure that you write these testing devices into your policies and procedures. Okay, versus the state surveillance testing program. So some background, most of you are familiar with this, but just in case you aren't, the state secured CARES Act dollars, and I have written down they secured $32 million in a pot for testing. Now keep in mind that they did not anticipate the CMS guidance coming out for mandatory testing. So, I think that they're working on securing additional funding, CARES Act dollars for this pot, but we'll see if they get that. So do keep that in mind for the state surveillance testing program. But there are some benefits to this, to participating in this versus using the point of care device. So if you were to choose to do this, you would find a lab to provide your testing for your staff and potentially for your residents. The state would reimburse that lab at a maximum of $85 per test. You can choose a lab, or you can go to this directory of laboratories at this link that I've included here on the slide. Now, if you've already been working with a CLIA certified lab, then like I said, you can choose that lab and they can apply for inclusion. And there's a link here on this next little bullet point. They can just go to this testing services contract and they can apply to contract with the lab. Okay, so, oh gosh, what did I do here? Okay, just to make sure, I think there has been a lot of confusion about the state surveillance program. So just to make sure that it's really clear, the lab is going to be the party that invoices and is reimbursed directly to and from the state. So you don't need to handle payment unless you or your staff are collecting samples from your staff members, the other staff members, unless they're taking the nasal swabs. So we'll talk about that in a second. All right, so then you, because you're going to be working with this lab, you'll execute a contract between your organization and this lab that you're going to be working with that's going to provide the testing. You'll also determine whether that lab, some other third party, or your staff members will do the collection of the swabs. If you're going to be collecting those swabs, this is number 3, then you'll actually have to contract with the state to be, because you'll want to be reimbursed for those services for that time that you're investing in that. And there's a way to do that. So you'll actually become a contractor with the state, and there's a link for that contract as well under number 3. All right, number 4, then you'll begin testing. For those facilities that are mandated, that fall under the CMS guidance, you'll follow CMS mandatory guidance if your building is regulated by CMS, or if your building is contiguous to one of those buildings mandated by CMS. I've gotten several calls from facilities that are like in I'm trying to think, like assisted living that's in a building where they're right next to a SNF or PC that's right next to a SNF. It is recommended that those buildings go ahead and follow this mandatory testing guidance because they're so close in proximity. I know it's a heavy lift, but just because of that shared space, unless you are able to justify a reason that you don't or that you shouldn't follow that guidance, it's really strongly recommended that you should, unless there's like some type of physical barrier between those buildings and that you don't share any type of staff. I would strongly recommend that you do follow it. Per the OIG, we've had these discussions. It's recommended that all Kentucky facilities follow this CMS mandatory guidance regarding testing. Now, he can't, obviously it's just a recommendation. He can't mandate that. So just keep in mind that that is a recommendation from the OIG. So for those facilities that are not regulated by CMS, you can do a few things. You can decide to forego testing altogether. That's not our recommendation. You can follow the guidance set forth by CMS. You can go ahead and like jump on board and do this mandatory guidance, or you can follow the guidance set forth by the long-term care task force. And I've included that here. If you're, say, a PC building or long-term care, or an assisted living building. Okay, but just make sure if you're one of those folks, just make sure you develop a testing policy and you're able to explain and justify your policy to the OIG and how you've come up with that policy. If you're participating in the state surveillance testing program, there is no reporting requirement because the labs conducting this testing will take care of the reporting requirement for you. So as opposed to the point of care, if you're participating in the point of care device testing program, you don't have to report. So that's a big difference. Okay, if for some reason, if you fall under the CMS, if you are regulated by CMS and you decide not to test at all, there are heavy penalties. There are heavy citations. These will fall under that F886 tag. And so I would strongly recommend against not testing. If you have documentation of attempts to comply, surveyors have been instructed not to cite for non-compliance. So say we get into a situation where tests are not available, it come fall, winter, when COVID and flu season kind of come to a peak, and tests become hard to get, that may become the case. So I would say make sure you document any attempts to get tests or secure your labs to do the tests. Make sure you're calling your local and state health departments if your tests are not available. Make sure you're letting the OIG's office and your state and local health departments know that you're making these efforts. And then I don't think you will be dinged for that, but just make sure that you're proactively letting everybody know that you're not able to get tests and that you're working on it. Okay, so finally, I think CMS has also revised their focus surveys for nursing homes to ensure compliance. At the end of that, at the very beginning, I linked to the QSO memo. At the very end, they've revised the survey tool, and I would encourage you to take a look at that tool. So finally, I think I've flown through this, and it's a lot of information. I know it is. I'm sure most of you have already taken a good look at this. So please take a look and type any of your questions. I know you're probably going to have a lot. Type questions in the chat box, and if we don't know the answer, we will be compiling lists to send to both CMS through AHCA or to the OIG. And I do know, Wayne, I think you could jump in here too. I do know that over the weekend, we've sent out a letter to our facilities asking, and Wayne, maybe you can jump in here.
Yeah, and that's a good point. We wanted to address the requirements that CMS has, the feds have, is obviously pretty onerous, and so we wanted to let the membership know that yesterday Betsy sent an email to Secretary Friedlander, basically with the ask to request the cabinet seek approval from CMS to have Kentucky's testing protocol be deemed as meeting the federal standard. So just wanted to let providers know, we don't know, I should say that we don't know whether that will be approved or not, but we did want to let membership know, and we'll send this out to, we'll let broad membership know as well as those on the call, on the webinar. But we wanted to let you know that we're trying to see if we can establish the state's protocol to be accepted by the feds. And also we're going to be requesting, and we would like to request each of you on this webinar to send in comments requesting the state allow this, because it will, I think, will make the testing process much easier and much easier to deal with, rather than having to adhere to some of the Fed requirements. So that's kind of in a nutshell what Betsy did send out yesterday. So we we'll keep members informed, but that is the request.
But I do want to make sure everybody realizes that in the meantime, until that request is approved, that we do have to follow this mandated guidance.
Correct.
Okay.
Do you want me to go through any reimbursement issues, Ashley, at this point, and then we can take
Absolutely.
questions. See if anybody has any questions in either the chat or the question.
Please
Okay.
do.
I did want to mention one of the things that we sent out first thing this morning, because we got late notice on Friday from HCA, is that there is an HCA webinar today. That webinar is going to be on the $2 billion of COVID relief that's related to infection control. That will be from 1 o'clock this afternoon until 2:30 Eastern time. Mark Parkinson and David Gifford will be reviewing the new rule, answering any questions and discussing any resources that are available for that. But I did want to mention that we did send out the reimbursement alert. There is a link to register, so registration is required. You do have to have an HCA login to be able to register for that, but I would encourage anybody on this webinar to attend if at all possible. And Ashley, I did want to go back, if I could, and just reference the different tranches or phases that the facilities have received. There's been 3 different phases of funding, and there's been 3 different really reasons for that funding. But the latest round, as most providers know, we got in phase 2, we got $4.9 billion that was just given to providers, basically to help with the situation of reduced census and the financial strains that facilities were incurring. But the latest phase 3 funding that facilities received is really related to helping out with the infection and mortality rates that facilities have encountered, and that amount that was just received by providers is to be used solely for infection control. And I just wanted to mention that's where that funding needs to be utilized. And I know Ashley has mentioned, that you do have to actually contract with the state in order to be able to bill the state should you choose to do the sampling if you've got a CLIA waiver. And we can send out in addition to that actual contracting that you have to do, we also can send out a link to an invoice form. You have to actually fill out a Microsoft Excel form to bill the state should you choose to provide the sampling. But as Ashley mentioned again, should you choose to go that route, she believes that you will need to comply with CDC requirements to report that information. So just FYI. But we can make that both I think Ashley included the contracting site in her slide, and we can also provide a link should you would like to the invoice form if you want to bill for that form. And just so you know, the amount, and when there's an issue with actually billing for that, the long-term care providers can bill using code G2024, and that is supposed to provide a reimbursement amount of $21.64 for that sampling. But however, when the provider goes through the contracting process, we've noted that, or in the contract, it states that the reimbursement amount is only $20 even. So the association has raised that with the OIG folks, and I'm assuming that'll be passed down to Medicaid, but to try to rectify that $1.64 difference. But if providers do decide to bill for the sampling, you can be reimbursed, be sending it to Medicaid or sending it to the cabinet, but it's actually CARES dollars that are paying for those testing costs. So did want to mention that. And I think that covers everything I had, Ashley, regarding reimbursement.
Okay, great. So we do have a few questions that have popped up here. The first one I see is, has the OIG given guidelines on when the 48-hour time frame starts? Is it the time that you obtain the test or the time that the lab receives? My understanding is that it's the time that the test is taken. So like the time the sample is taken. So you are supposed to be getting those test results back within 48 hours of the time that test is taken from that individual. If that isn't happening, and I know that's a tight turnaround. But you know, if that's not happening with some of these labs, please let us know, and we can let the OIG know, because that's kind of the, you know, the labs have said that they can do this. So please let us know if that's not happening. And that should be what, you know, is negotiated in your contracts with the labs when you initially work on those contracts. And I know that, you know, that now this is just kind of, you know, all these little nuts and bolts are being worked out now as we go along. Wayne, do you have any input on that as well?
No, I don't. That's about all I have. And I did notice, Ashley, one of the other questions that was submitted, or comment really, is that the problem that I just mentioned, the $21.64 amount, evidently they've responded to Betsy's inquiry to the OIG and Medicaid, and that has been rectified. So the contract amount is currently stated properly at the $21.64.
Okay. All right, I'm having trouble seeing these questions. Wayne, is there any way you can like read them off to me?
Yeah, or Angela, if you've got it there.
Yeah, I do. If a facility is having to test twice weekly, would it be possible to use both the contracted lab and the POC rapid testing device?
Sure. I mean, you can use a combination of the two different testing mechanisms. Absolutely. Just make sure you're following, you know, the two different. My biggest concern in folks doing that is to make sure that you're, you know, following the guidance. And then also, you know, the biggest hang up with that point of care device is the reporting, I think. So just make sure that you're doing that reporting with that point of care device. But yeah, absolutely. I think you can use a combination of the two different mechanisms.
Okay. And then the next question was Wayne just read that one. So that's all I have so far.
So the national bed information was taken to determine, you know, how much your facility receives. But if you do have any questions regarding that amount, you know, feel free to give me a call. But again, those dollars are to pay for the testing process that Ashley just went through.
Okay, and then we did just get another question in. It says, is there a grace period for this? That was probably a follow-up to the question you just had.
Is there a grace period? Hopefully, is there a grace period to the guidance in general? Unfortunately, not. So the guidance started on the 2nd, and to my knowledge, I think facilities are supposed to have started working on this on the 2nd. So just be watching that county positivity rate. And if you can, I mean, I think our OIG is going to be a little more flexible, but I wouldn't count on that. So if you know, just make sure you get on this as quickly as you possibly can and have some justification for, you know, if you haven't gotten on it yet, then have some justification for why you didn't.
And I think for those that, or the individual that asked that question, I think that issue is going to be raised on the HCA call this afternoon with Dr. Gifford. So I do encourage those that are on this webinar to try to get on that call. I think it'll be good to get that information and some additional information as well.
Okay, we did just have another question come in. It says, after the 14-day outbreak testing is completed, for instance, when an employee is positive, is there any further testing of residents required until there is another positive or another situation that warrants further resident testing?
Okay, I have to think about this because it's like an if then.
Yeah.
After the 14th.
The 14-day outbreak testing is completed, for instance, when an employee is positive, is there any further testing of residents required until there is another positive or another situation that warrants further resident testing?
So if I'm understanding the question correctly, if you're doing all of the outbreak testing, if that outbreak testing is completed and you're doing all of that testing until you know that there are no more positives in the building, period, then no, there is no more testing required until there's somebody that's asymptomatic that pops up. I'm sorry, you'll do your routine staff testing. You'll do your routine staff testing, but you won't test any residents until you know that there's somebody symptomatic. It's complex.
Yeah. And if that didn't answer your question, if you, yes, she said it did answer her question. Thank you.
Okay. Sorry.
No. And the next question says, I've heard that facilities might be paid a premium daily rate based upon number of cases in our building. Is that true, or is this true?
Yeah, I think that question is relating to, this is the latest phase, or the latest tranche of funding was $5 billion to nursing facilities. And the nursing facilities received $2.5 billion, again, based on their number of beds. And I think this question is referencing the next $2 billion that facilities are going to receive, and that will be, as I referenced before, going to be paid out in 500 billion amounts per month nationwide. And what I think what that 500 billion is going to be based on is it will be based on their COVID rate in comparison to the counties. We've not received the details on how that's going to work. That may be also addressed in this afternoon's HCA call. But that 500 billion is basically going to reward facilities, if you will, that have lower COVID rates, and they're calling it a value-based purchasing, which I don't know if that's a good term, to be honest, but because there are good buildings that have been hit very hard with COVID, it's just not related to value at all. But that is how they're going to determine that payout, and that's going to be done, I think, starting in October, and each month after that for the next 4 months. That is the way that that rate will be paid, or that those facilities will be paid.
Good. Well, so far, that's the only questions I have at this time. So if anybody has any more, feel free to, again, type those in, the questions into Ashley and Wayne for us to read out to everyone.
Phew, we got through my most dreaded question about the 2 weeks.
All right. Any other questions? I have heard that some people had some trouble with the handouts, not being able to download them. So I will email those out to everyone, because I know some people want the specifics on that, Ashley. So I'll make sure I can get those out to everyone today. I don't see any other questions.
One thing I'll mention is, if anybody needs to get a hold of me quickly, because I know that with some of this stuff coming up, I'll give you all my, because I don't know if everybody realizes this, but with this pandemic, we're not in the office most days. Some of us kind of filter in and out. But if anybody needs to get a hold of me quickly, my personal cell, we kind of combine personal and work cell phones, but my cell phone number is 502-220-8860. I'll repeat that, 502-220-8860. And I will say, because we're on so many webinars and calls, texting or email is probably the best way to get a hold of me. But anytime, just shoot me a question or a comment or a concern, and I will do my best to get back in touch with you as quickly as possible.
So since Ashley gave hers out, I guess that means mine as well. My cell number is area code 502-905-5834. So you can text or call, and again, email is a good way to get a hold of us. But as always, feel free to reach out to, with this testing going on, it's a very complex and it's fast moving, just as exemplified by the HCA webinar that we didn't even find out about until Friday. So everything's just fast moving, and we certainly understand we need to try to help you out as much as possible. So feel free to call.
All right. Still don't have any other questions. So anything from you, Ashley or Wayne, that you need to share with the group?
I think that does it for me.
All right.
That does it for me too.
And again, just I'll go ahead and put a little plug in regarding education, since I always like to. We have quite a few new webinars that were just put up on our KHCF website, including one at the end of the month that we're going to have on survey process, that we're going to be having the OIG, Jackie Adkins, and then also Jackie Strader, a consultant, presenting for us. So again, if you want to check out any upcoming webinars, we have quite a few coming up this month. Thank you. And so I will again send out the handouts to everyone. If you have any questions, feel free to email or contact Ashley or Wayne. Thank you all.